Dr. Ann Maitland. Dr. Maitland is Director of Allergy and Immunology Services at the Metrodora Institute and professor at the Icahn School of Medicine at Mount Sinai in New York. She's a fellow of the American College of Allergy, Asthma, and Immunology and member of the American Academy of Allergy, Asthma, and Immunology. She's an expert on immune-mediated disorders and has several publications on immune dysfunction and mast cell diseases. Today, she will present to us on the price paid when the immune system misfires. Welcome, Dr. Maitland.
Thank you. And I'm hoping that I won't have the, just in case, I think I should be able to access. Again, thank you for the organizers for this very unique opportunity to talk about a cell population that has gotten very little attention until the past decade or so. And we're going to be talking about mast cell dysfunction, but in the context of what happens when inflammation goes awry, starting at the level of the epithelium, talking to the nerves, as well as the mast cells. And if we can go to the next slide. These are my conflicts of interest, and the ones I may touch upon slightly is the fact that Metrodora is involved in 2 long COVID trials with companies including argenx and Grifols. Next slide, please. So I'm going to start off with this quote from Albert Einstein, who says the world is a dangerous place to live. And if we go to the next slide, he was referring to what's happening with on the levels of cities, countries, as we are witnessing in quite a few hotspots on our planet. But I'm going to bring it down to the level of the individual dealing with the surrounding environment. We have, at least the average adult has 75 square feet of territory that needs to be guarded, dealing with the external environment, including our skin, the linings of our respiratory tract, gastrointestinal tract, as well as urogenital tract. If we go to the next slide. And so almost a century ago, notable scientists described what our tissue defenses consisted of, and they named it the immune system. There are several components, including the epithelial layer, and then you have the innate cells, including mast cells, as well as proteins called complement. And then you have the adaptive immune system, for which a lot of research, whether we're talking about ME/CFS, HIV, or long haulers, as well as long COVID, has a tendency to focus on the adaptive as well as the adaptive immune compartment, meaning B cells and T cells. But a lot of the action actually starts at the level of the epithelial layer and the cells that are juxtaposed to the epithelial layer, and that's going to be the somatosensory network as well as the mast cell compartment. If we can go to the next slide. So, if you go down to the level of the organ system, you have the epithelial layer that's interacting with physical triggers, infectious challenges, even toxins, or chemicals, whether they are naturally occurring, such as stinging insects, or manufactured, such as medications, or cleaning agents. And it is up to the epithelium to kind of say, I'm happy with this exposure or not. And if it's not happy with this exposure, signals are sent both through the somatosensory network, chemicals that can actually cause pain, itch, for instance, as well as the mast cell compartment. And if we go to the next slide, it's called the interactome. And so what we have is this cooperation between the epithelium, the nerves, and the mast cells in every part of the organ system. It is this triad that is interacting with the environment to make a decision of whether or not the immune system should start taking resources from the maintenance and operation of the organism to an inflammatory response in order to contain a perceived or actual danger. And if you go to the next slide. So, in many ways, the nervous system and the immune system, especially the mast cells, are equipped with receptors to detect change. And again, whether this is a chemical change, a physical change, these changes can be external or internal. And they warn the body and then actually initiate protective services in order to protect the organism from potential or impending dangers. And the ability to sense tissue injury from the epithelial lining leads to the change in activation of both the mast cell compartment and the somatosensory network. If you go to the next slide. So this neuroinflammation, I have to, and I find it very interesting that this communication can lead to the release of various chemicals from the mast cell compartment that can impact the activation, recruitment and activation of various immune cells, can actually change the composition of the surrounding microenvironment regarding the ability of very potent enzymes to modify the tissue. And mast cells have the ability to release both platelet activating factor and heparin, which can change blood flow. So you can see how these cells, and just let you know, compared to like T cells and B cells, there's not a single human born without mast cells. So having functional mast cells and align with meeting the needs of your homeostatic balance is essential to life. And what we have found is that there is a deviation of this neuroimmune axis in individuals that have ME/CFS as well as long COVID. And so if we can go to the next slide. So, and why I use the term the price tag. For instance, the US has a large percentage of its GDP dedicated to the military because it's important to protect from dangers from without as well as from within. The body does the same thing. And the signs and symptoms that something is wrong, like that red light that comes on your car if something is wrong with the engine or the tires, for instance, the cardinal signs of your neuroimmune axis changing its pattern of activity is going to be pain, heat, redness, swelling, as well as loss of function. You go to the next slide. Now, in many ways, you're willing to pay that price if you're trying to prevent infection, if you're trying to recover from some type of physical or chemical wound, as such that the tissue surveillance and defense was thought to provide absolute protection against a noxious agent, or at least the occurrence of some process strictly advantageous to the host. But if you can just advance one step, nobody could imagine that this system, which was designed or thought to be only for protection, could harm the host. And what we have seen within the past 50 years is this axis is actually contributing to a new burden of disease. And so if you go to the next slide. So this is an article from the New England Journal of Medicine talking about the role of infections leading to both immediate and delayed hypersensitivity disorders, also known as autoimmune and allergic diseases. And you can see by the time the 1980s runs around, we're starting to see a huge increase in both immediate and delayed hypersensitivity disorders, including inflammatory bowel disease, as mentioned earlier about, the parallel between multiple sclerosis as well as long COVID, asthma, rhinitis, food allergies, and type 1 diabetes. So if you go to the next slide. So in a sense, the burden of disease went from suppressing major infectious agents to a loss of tolerance, increase in hypersensitivity. To the left are classic mast cell disorders, including neurocognitive impairment and headaches, susceptibility to asthma, anaphylaxis, interstitial cystitis, or bladder pain syndrome, food sensitivities, pain sensitivities, and also disruption of the skin integrity in the form of urticaria, flushing, and even actual swelling. Forms of delayed hypersensitivity disorders, and as alluded to in the previous review article, that we also see on the rise is not only Hashimoto's, multiple sclerosis, celiac disease, or non-gluten sensitivities, rheumatoid arthritis, and other rheumatological disorders as well as skin disease. And then I'll add to this COVID because it seems that the hyperimmune response may be contributing to both immediate and delayed hypersensitivity disorders, which we know by a different name, but now are falling under this umbrella of individuals having signs and symptoms worrisome for loss of tolerance after SARS-CoV-2 exposure. We go to the next slide. So as many of the speakers have talked before, long COVID is a huge problem. The estimate here in the US is about 7% of the adults who have been impacted. And I don't want to forget children who are also impacted by long COVID, as well as our elderly. This is a huge problem. It's draining our resources. And more importantly, we're not taking care of our neighbors. If you go to the next slide. So the first proposal that it is a hyperinflammatory immune response contributing, or at least one of the contributors to the development of long COVID, focuses on the individual's ability to deal with a particular viral exposure. So there have been different variants that have had different pathogenesis, and then I can't emphasize more how important it is to understand that not every person brings the same resources to deal with this type of viral exposure. And this is what the slide to the right addresses, is the fact that individuals that have controlled infections after a SARS-CoV-2 exposure are much more likely to survive and also much more likely not to develop long COVID. But we also see individuals who have intrinsic issues or acquired issues that lead to a poor innate immune response. And because there's a poor innate immune response, you start exhausting the adaptive immune compartment. Understand they're the called in help, not the first responders. So if you don't have a good first responder response, you are at risk for developing the sequela of increased mortality as well as increased morbidity, including long hauler COVID or long COVID as well. Next slide. So some of the potential mechanisms talking about how acute inflammation goes awry leading into chronic neuroinflammation focuses on the fact that you may have not had the same resources to have an appropriate immune response. So there's primary or acquired immune dysregulation. For some reason, either your lymphatic system, your immune system, or the epithelial lining itself are not able to eliminate the antigen. The antigen persists, and that can end up recruiting more neuroinflammatory responses. So this is relevant to what I believe was mentioned earlier, is that sometimes you don't need intact viral particles to cause a persistent neuroinflammatory response. You also have individuals that have intrinsic issues with susceptibility to tissue damage. And because there's tissue damage, the immune system will continue, the neuroimmune axis will continue to activate as though that there's a danger that needs to be dealt with. And then you also have the ability to not clear the danger, such as the SARS-CoV-2 particles, such that that allows for, it's almost, you're developing inappropriate T cell and B cell responses that lead to immune complexes. And those immune complexes basically sit in the tissue, causing more activation of the innate immune system. And so it's really important to understand there's lots of different flavors of neuroimmune deviation that can contribute to the development of long COVID. And in order to sort out how you can help individuals with long COVID, you need to understand what parts of the immune system are overacting, underacting, or both. And go to the next slide. So I'm going to speak as an allergy immunology specialist who kind of backed into the COVID pandemic. And I recognized almost a decade ago that mast cells did a lot more than, recognize peanuts and cause people to have a bad allergic reaction. These are multifunctional cells that have the ability to modify your blood flow, have the ability to recruit and activate other immune cells, have the ability to modify structural cells such as astrocytes, as well as other epithelial structures of different organ systems. And it is that triad between what is the barrier dealing with, and if it's impaired and allows more antigen to come in, you're going to have chronic activation of that nerve and neuron axis. It's a complex interplay that needs to be deconstructed and then reconstructed in order to identify tailored therapies for the individuals that are impacted by long COVID. We go to the next slide, please. So just to kind of give you an idea of what's happening, you have the virus that can typically is going to be inspired through the nasopharynx or oropharynx, and understand that sits right next to the brain. And we have other conditions that we know that are associated with chronic infection or abnormal responses to infectious agents, such as individuals that are impacted by PANS or PANDAS, and other diseases such as allergic fungal sinusitis. It is an impaired response that leads to chronic activation of this axis. And without an efficient innate immune response to clear as much as the organism as possible, and then call in appropriate adaptive immune help in the form of T cells and B cells that recognize the important parts of the virus or the bacteria to clear that pathogen, you can end up with an ineffective innate immune response that will then lead into an ineffective adaptive immune response and inappropriate clearance of this danger. If we go to the next slide. So in many ways, I think it's important, and just to give the vocabulary to the patients impacted by long COVID, sometimes it's important to understand what flavors of long COVID do you have? Do you have evidence of POTS, or neurally mediated hypotension, or chronic headache disorders, or abdominal or central nervous system migraines? Or do you have evidence of mast cell activation disease? Because I can tell you, if the mast cells are misbehaving, the nerves are going to get involved. And if the nerves are hurt, the mast cells are going to get involved. In many ways, individuals that have mast cell activation disease, including mast cell activation syndrome, and I'm just going to stick with the word disease because we don't have enough objective markers to give people that diagnosis of mast cell activation syndrome. So mast cell activation disease is a better working diagnosis for individuals that are at risk for both immediate and some delayed hypersensitivity disorders. But I can tell you, mast cell activation disease can be multi-organ system, just like individuals that have autonomic dysfunction. And again, that just illustrates the crosstalk between the mast cells, the somatosensory network within the tissue that's being impacted. So if you go to the next slide, please. So I think it's really important to start with, do you have mast cell activation disease? And this was proposed initially after the allergy epidemic kind of took hold, probably in the 1990s to early 2000s. There are several practitioners were identifying individuals that were having reactions to foods, to environmentals, to chemicals, to even the clothing that they wear, and IgE testing was negative. So instead of talking about a potential trigger of mast cell chemical mediator release, the focus is, can we see whether or not the mast cells are misbehaving and causing one's organ system issues? And so the diagnosis of mast cell activation syndrome, which falls under the subset of mast cell activation disease, is, do you have mast cells misbehaving in at least 2 organ systems? So if you check any one of these boxes in the left-hand panel, then you have to ask, well, is this a mast cell disease? And I'm not saying whether mast cells are broken or mast cells are breaking bad, as the analogy that was used earlier in this webinar series. And then the next question is, do you show some improvement with medications that target the mast cell compartment? And so you have antihistamines that are over the counter, such as diphenhydramine or loratadine. And then you have H2 blockers, such as cimetidine or famotidine. You have the chromones and ketotifen, and you have a biologic called omalizumab. I can also tell you prednisone will impact mast cells, but it also impact other cell populations. And as was mentioned before regarding lorazepam, just as much as it impacts GABA, it also impacts the mast cell function as well. So, but for the diagnosis of mast cell activation disease, you need at least the 2 or more organ systems and showing some improvement with the medications that are on this list. The hardest thing to secure is the objective data, and that is just one advancement of the slide. And these are the markers that give us an idea that the mast cells are a major contributor to the signs and symptoms that a person might be dealing with. So the gold standard marker is tryptase, but I can tell you, I can check tryptase and people have food-induced anaphylaxis all day long. It's never elevated. And by the way, mast cells are not one-trick ponies. They have a lot of other chemicals that they release, as I said. So some of the surrogate markers that we try to see whether or not mast cells are driving at the symptoms include 24-hour urine collections of histamine and prostaglandin metabolites. But remembering that mast cells are tissue-based cells, very few are circulating around in the blood, you really need to kind of go into the tissue and see if there's an issue. And one organ system that I think is readily available is the skin, and then the other is the gastrointestinal tract. But unless you tell the gastroenterologist, the dermatologist, and then the pathologist to stain for mast cells, you will not see them. And then if you do light them up, it's important to understand that there's certain characteristics that suggest that these cells that have very potent chemicals that you really only want out there when you really need them are chronically activated. And I often tell a lot of patients that come through our doors, it's kind of like having a police officer who does not put their gun back in, even though the person has already been taken off to jail or is on their way to some type of secure place so they're no longer a danger. Mast cells, chronic activation of mast cells will lead to chronic neuroimmune pathology. So if you go to the next slide. So this is a questionnaire so that you can fill, and I'm happy to make my slides available, but if you check at least two of these organ systems, that's something that would warrant you being evaluated by somebody who has some expertise in understanding mast cell activation disease. So literally, it's just taking a really good history, and I'm hoping that this questionnaire will provide you with the ability to give a really good story to a lot of practitioners who have had less than 2 weeks of education of the immune system during their training in medicine or nursing or physical therapy. The next slide, please. Then once you decide that your mast cells are misbehaving, you need to understand why. Do you have a very rare disease such as mastocytosis, less than 32,000 cases in the US? Do you have another mutation within a molecule that's only found in mast cells, the tryptase? And we have found that 7% of the Caucasian population will have a multiplication of that gene. But that is saying that instead of carrying a small weapon, you're carrying a much larger one with an extra cartridge if you have that mutation. But the majority of patients that have mast cell dysfunction, it's actually the mast cells are breaking bad because you have developed an inappropriate immune response, such as using IgE that's used to recognize parasites to go after food or medications or environmental allergens that are harmless otherwise. You have another undiagnosed disorder, such as an undiagnosed immunodeficiency, an undiagnosed cancer, or an undiagnosed infection. You may have a genetic predisposition to miscommunication between the mast cell compartments and the somatosensory network, and that is readily seen in individuals that have recurrent hives or urticaria. That can happen for physical triggers, such as you strike your skin. So if you strike your skin and you welt up, that is a mast cell disease or a neuroimmune disease. Other miscommunications are individuals who don't tolerate changes in climate or they don't tolerate changes in temperature. So these physical triggers actually cause the nerves to say that this is a dangerous situation, and that is communicated to the mast cells to release these chemicals inappropriately. And lastly, just like any other cell in the body, the mast cells can be a target of the immune system, other components of the immune system as well. But it's really important to understand not only whether you have mast cell disease, but why your mast cells are misbehaving, because then that is going to influence what therapies can be recommended. If you go to the next slide, please. So these are some of the tests that I use to try to sort out why your mast cells might be misbehaving. Some of this testing has been done already. Sometimes we just need to revisit with a different pathologist to interpret the testing. Some of it just to see whether or not someone has an undiagnosed connective tissue issue. This is a questionnaire that was developed in France, where they have 3 standalone EDS clinics, and they basically say if you had any 5 of these 9 syndromes, and it just says it's a yes or no, then you should be screened for connective tissue disease. And I can tell you, individuals that have heritable disorders of connective tissue, such as Ehlers-Danlos, Marfan's, or osteogenesis imperfecta, they're at increased risk for having issues with their somatosensory network and having proprioceptive defects. And because of that, the mast cell compartment will be more easily triggered to inappropriately releasing the chemicals. Now, if you go to the next slide, please. And I just want to mention that not everything that has itch or hives or abdominal pain is a mast cell problem. So there are other syndromes that can look like mast cell activation disease, or they're the primary driver of causing the mast cells to inappropriately release them. And if you advance the slide once, I would like to highlight that postural orthostatic tachycardia syndrome. So nerves that are not very happy will talk to mast cells, and that will help perpetuate that neuroimmune deviation. And if you advance the slide one more time. Autoinflammatory disorders. It's interesting. We're starting to identify through genetic testing individuals that basically release the alarm a lot sooner and a lot more so than individuals that don't have these genetic variants. So individuals, for instance, that have familial Mediterranean fever or periodic fever syndromes, this says that you're having chemicals released from the epithelium crying wolf, and when there really isn't the case. And then once you decide what part of the triad of the epithelium, the nervous system, or the mast cell compartment is tipping your homeostasis is tipping your symptoms, then you'll be able to use different therapies that are tailored to why you might be dealing with long COVID. So if you can go to the next slide, please. So I really would say you should, if you've been diagnosed with POTS, or if you've been diagnosed with long COVID, if you can just advance the slide, you should be evaluated for mast cell dysfunction. And then by looking at whether you have mast cell dysfunction and try to figure out why those mast cells are misbehaving, like, are you having problems clearing the viral particles? Did you not have enough defenses to motivate or mobilize an appropriate innate immune response to contain the virus so that you weren't so dependent on T cells and B cells that might not be up to par with dealing with this new pathogen? So if you go to the next slide, please. So in many ways, I would say, is long COVID a problem with that neuroimmune axis not shutting off or not shutting on appropriately, or not coming with appropriate resources in order to contain that virus so that you don't switch into a hyperimmune response? One analogy I often give patients is, if your house is on fire and the police show up, you're not going to be upset about that. But to be honest, the police don't know necessarily how to put out that fire. They might be able to prevent you from getting more harm, but that's about it. So the question is, when you get exposed to this virus, did you not have enough resources to contain that virus appropriately, such that you didn't have to use less effective means of defense to get that virus under control? And now you're using compensatory mechanisms that are inappropriate and potentially causing more damage and pathology. Next one. This is a paper that I had put out about 2 or 3 years ago with 2 colleagues. And we basically looked at individuals retrospectively who came through my office saying I had mast cell activation disease. And what I found very interesting is that 1 out of 5 individuals with these persistent symptoms of mast cell activation dysfunction had evidence of immunodeficiency and also had evidence of connective tissue disease. And I have to tell you, the top 3 symptoms that most of these patients were complaining of were gastrointestinal distress, neurocognitive impairment, and skin symptoms. Next slide, please. So this is kind of give you an idea of, if you can figure out what part of that axis or what parts of that axis is misbehaving, then there are tailored therapies which are growing in order to help individuals that are impacted by long COVID. For instance, if you have evidence of issues dealing with the epithelium, talking either to the nerves or to the mast cell compartment, you have acupuncture, physical therapy, compression garments, tricyclic agents, anti-CGRP therapies, vagal stimulation, and oxygen therapy. If there's an issue about the epithelium itself having increased susceptibility to tissue injury, we try to use therapies that help either restore that barrier or go after reducing that signal, like individuals who are diagnosed with autoinflammatory or hyperinflammatory genetic predisposition. Then you have individuals that have miscommunication between the mast cell or the nerve compartment and the adaptive immune compartment. And there it's a plethora of antimicrobials, depending on what flavors of immune dysfunction have been, of the adaptive immune compartment have been identified. Next slide, please. So, and I also want to lean into one of my dear mentors, Dr. Shuman Lee, who was the former head of the East-West Center at Mount Sinai and now runs her lab out of New York Medical College, where we have seen use of traditional Chinese herbal medicine as well as acupuncture and acupressure actually reverse chronic hypersensitivity disorders. And again, you have to prescribe these therapies just as you would prescribe like clonazepam or a biologic. Next slide. So I'm going to wrap up here with saying that in many ways, there seems to be a prominent role of neuroimmune dysregulation contributing to long COVID. To the right is a paper that came out in early 2020 talking about the role of addressing mast cell dysfunction contributing to coronavirus provoked inflammation. And then to the right is actually a case report of one of the patients that came through my practice who had COVID early on. And we actually were able to kind of stabilize her symptoms with a combination of medications directly targeting the mast cell compartment. And she was also found to have an immunodeficiency as well as autoantibodies against her nerves. So using IVIG along with other immunomodulating agents, we're able to stabilize her back to a baseline and preventing the complications of her developing long COVID. Next slide, please. So in summary, signs and symptoms of long COVID seem to overlap that we see in primary nerve mast cell dysfunction syndromes. And by identifying what might be overactive or underactive or both in these individuals, you can then identify tailored therapies. And it was asked earlier on how you can prevent being gaslit or not listened to by a practitioner. Our healthcare system, I can't speak to other countries, but in the US, you have 3 minutes to identify your symptoms to a practitioner. So I have 5 things that I tell patients to do, and I tell them they can use it with me as well. If they start telling me a story, do I recognize anything that smacks of a condition that I might be able to sort out with further testing? The second thing is, what can I give you to make you feel more comfortable as I'm trying to tease out what might be contributing to this neuroimmune dysfunction? Third thing is, whatever I give you, there's a potential side effect. So I need to warn you about that as well. The fourth thing is, what testing am I going to get to try to better define what I think might be going on or contributing, including bringing in other consultants and acting as a team, because I find that a lot of these patients are like Maseratis, and unfortunately they're being treated, no offense, like a Yugo. So we have to kind of have a really good pit crew captain and who's able to coordinate the care from the different specialists a part of that team. And then lastly, I really just want to emphasize again, mast cells are multifunctional. They are crucial to our existence, and it's not a question about eliminating the mast cells, it's just rehabbing them to make sure that they're contributing to our health and not perpetuating forms of disease. If you go to the last slide. I just want to extend my gratitude to the organizers of this meeting. I hope you found some helpful hints and suggestions. I have a lot of people to thank along this 2-decade-long journey about the immune system that unfortunately is completely underrepresented in many countries, including the US, as well as what I just discovered in London, Spain, and Germany. There's just very few people who are trained on the immune system. And then these are some of the patient societies that I've actively participated in, these are individuals that are dedicating their time, just like, Unite to Fight, to get better answers, to better education, not only of the patients, but the practitioners who took an oath to help. Thank you.
Thank you so much, Dr. Maitland. That was a fascinating presentation, just chock full of information. I think we'll only have time for one question in Q&A now. And so the top voted question from the community was, should we, I think meaning long COVID patients, rather strengthen our immune systems or take immunosuppressive measures?
Maybe. It all depends. So it's really important to understand we have individuals that have intrinsic susceptibilities to having an overactive immune system. So using tailored immunosuppressants would be helpful. There's some individuals that have undiagnosed immunodeficiencies, so using medications or a combination of therapies. And it's not just medications. We've seen that if you have cervical spine instability issues, you're going to have increased activity of the immune system. So suppressing the immune system without going after your neck is not going to make any benefit. So you really need to, there's not going to be a one trick helps all. You really need to kind of get a better picture. I love the comment from the Ehlers-Danlos Society where not one single zebra has the same stripes. So the question is, what are your stripes? And what do we have available to go after those stripes that seem to be miscommunicating?
Again, thank you so much for being here. Thank you for your patience through the little technical glitches that we had. It was wonderful to hear from you today. Thank you again, Dr. Maitland.
My pleasure.